see that okay now. So, but I'll introduce myself. I'm the director of development for our behavioral health service lines with psychiatric medical care. I live up in Des Moines, and our organization is actually based out of Nashville, Tennessee. So, I guess first and foremost, I apologize for our neighbors to the south that are having what feels like a much more worse winter than the folks up here in Iowa experience. So, I hopefully the warm up is on its way. It sounds like so. Anyway, it doesn't seem quite right. But do want to talk a little bit about just some of the challenges out in mental health, and then overcoming those, and give you guys some idea of our company overview. Our mission and vision really is all about trying to increase and provide access to many mental health providers in the rural areas that we serve. So that's really our bread and butter, and really strive to achieve that. So we've got a couple different just service lines that we'll try and hit on today that cover, I think, a fair amount of what is out there in the behavioral health world. But our Senior Life Solutions program is an intensive geriatric outpatient program that's hospital based, and is really specifically for kind of the critical access hospital market, and targeting those hospitals that are in the and certainly in the rural areas. Our ITP division is an organization that provides ED crisis assessments. So for patients that present to the ED, to our hospitals in crisis, we're able to get those individuals seen and assessed by either a psychiatrist or a psych NP, to provide some support to the ED physicians in that arena, and then get them to the next level of care. We know the ED is not certainly the place for them or the destination for them, and so we want to try and help support that. And then we also do some outpatient work through that. And then thirdly is the other area we're focused on is just inpatient psych management. So with an inpatient organization or hospital or designated unit, we can help support that either through just giving the providers a break from overnight coverage, call coverage, weekends, or just help manage it. So just a quick overview on kind of who we are as an organization. So a little bit about the kind of the scope of rural America, and where the challenges lie. And rural is defined as outside an urban area, basically of I think 5,000 people, but 20% of us live in rural areas. So it's really, our country is still built on rural America, and that amounts up to about 66 million people. So the reach of mental health, because of that, certainly extends greatly. We've got 17 million adults that live in rural areas with some sort of a mental health illness, and 1 in 4 adults, U.S. adults, live with a mental illness. So we certainly understand that, we realize it, and want to try and help with those numbers and access. So, kind of what the scope and scale looks like. Again, from an access standpoint, 65% of rural counties do not have a psychiatrist, and those suicide rates are nearly double what we see in the urban areas. So, a number of Americans live in an area that's a rural designated mental health provider shortage area. So again, these things are all certainly known. I highlight them just to bring focus to the need for specialized mental health services in those areas. So kind of post COVID, certainly the impact on mental health was prevalent. 32% of adults reported some sort of symptom of anxiety or depression, and then 36% were women, and about 28% of that was men. So certainly that had an impact, and kind of excited to move beyond that part of it, and from the pandemic, but we know that those factors and those impacts still remain. So drug overdose rates increased, and 90% of the U.S. adults believe the country is still facing a mental health crisis. And I think all of you that are involved certainly probably see that firsthand as well. Hospital CEO survey that was done by the American College of Healthcare Executives is some of the results of that. The number one concern was workforce, but peeling away a lot of that, it goes down to just the behavioral health and addiction issues that are out there. So lack of appropriate facilities, programs in the community, lack of funding for addressing behavioral health, and just a lot of it sometimes related to overcoming the societal judgment and the stigma around mental health as well. So certainly prominent amongst all of our hospital partners that we look at. And so some of those impacts, obviously in the ED that I mentioned, a number of visits related to mental health and substance abuse are rising. We see that across not only the state of Iowa, but in a lot of the hospitals that we're working with. 25% of those patients end up being admitted to a general hospital, also had a behavioral health diagnosis. So they may come in with a medical diagnosis, but then there's an underlying, behavioral health concern as well. And 55% of people are transported to an ED for a mental health crisis, ended up being admitted for, for an evaluation. So, and again, that's not the area we want to try and, treat mental health. We want to get them to the appropriate level of care, outside of that ED setting. So some of the wait times that we see in the ED for mental health certainly are much longer than what the normal wait times would be for patients. On average, it's 40 minutes. Wait times for behavioral health just to simply see a provider or get services can be 3 times that. So, and then that doesn't even really factor in the amount of time that can be spent trying to find a referral bed or something along those lines. And that bed just occupies, the opportunity for another patient to be able to seek treatment. So I know some of the dollars we've seen around just boarding an ED patient can get up into the $2,600 and higher range, depending again on how long they're there. And I think even some of the services that are available, it can be even more challenging when we're dealing with young adults, adolescents, and that type of thing, just because again, sometimes the services are limited for those individuals. So some of those challenges within the ED, 11% of the visits involve a mental health diagnosis across all ED visits. And then 13%, sometimes report taking hours and even days to find that referral location for a hospital. And they're just very challenging for ED physicians. They're not, typically trained on managing behavioral health. They get a very limited time within their residency program around mental health. And so, being able to help support them and in their work certainly is advantageous. So, other challenges that we see in rural markets, just around lifestyle, it can be certainly an isolation situation or due to the loss of a loved one, living alone. You got lower median incomes. A higher percentage of the individuals are older adults in the rural communities, simply because they've been there, they've raised their families there, and so they may have limited internet access in some cases. And again, I mentioned the stigma, which is still something that kind of generationally with our older adult population is can be challenging to overcome. So obviously mental health shows up on almost all the community needs assessments that are done or that we see done. 25% have an experience, adults experience some sort of mental health issue, and especially that older population. But I don't see that certainly changing anytime soon. And more concerning is the amount of people that just don't receive any sort of treatment and go uncared for. And that's certainly something that we want to see addressed and have an impact on changing. In our rural markets, there certainly can be some reimbursement challenges as well. So inadequate reimbursement rates is one of the reasons people don't have access or can access behavioral health. The other one may be around just providers can make billing patients directly versus accepting Medicare more opportune. And then in a kind of a secret shopper type of analysis that we're done, appointments can be long to get, and the wait time can be certainly exceeding. It shouldn't necessarily take 90 days to get in to see a provider, but it can be 90 days or longer sometimes to get into a mental health provider, and that's just that's hard to kind of imagine if you were somebody that was suffering from a mental health illness or crisis. So some different models that we as an organization have put out there that certainly can work, and we've seen work. I mentioned the Senior Life Program. So this is an intensive outpatient program. It is specifically designed for critical access hospitals in that older adult population. It sits underneath inpatient, behavioral health, Jerry site care, but above just regular outpatient care, simply because it's more intensive. It's a 3 day a week program during the week, and then our staff that actually is at the hospital and is hospital based is there 5 days a week, and is able to offer individual therapy as well as family psychotherapy, and it doesn't require a provider referral to be admitted to the program. But it is a much better option than kind of inpatient hospitalization. And we've got 10 hospitals across Missouri today that have this program installed in their hospitals, and are seeing great results and success with it as well. So some of the common diagnoses that we see for people that are referred to the program are anxiety, depression, major depressive disorder, maybe some type of a life change, a medical event. Those type of adjustments can be challenging for the older adult population, and just aging in place. Again, living alone, isolation, or having a specific medical diagnosis. Those kind of things are all fairly common with folks that we see in our programs, and are very treatable, and give people kind of a renewed happiness and just zest for life. So it doesn't have really a start and end date. It's all individualized. So the program itself is overseen by a psychiatrist. So just the ability to get somebody in a rural setting in front of a psychiatrist within a couple weeks is almost unheard of. So we provide that opportunity for them to do that, and then these individuals then are also, there's a program therapist, a program director, as well as a coordinator that are based on site to help with just program management, mental health management, and ultimately we kind of become that mental health community partner and the expert in mental health within your community, to help manage and treat those folks. So not only is the group and individual and psychiatric care part of it, but they're able to do wellness assessments, help with medication management, and just other environments of care as well, making sure everything is safe at home. And I know our team this time of year shared stories about even just being able to help somebody find snow removal service, or help with their phone plans, and those kind of things that again, generationally can be a challenge to help manage, and we can help with that. So there was a pilot that was done on an IOP, intensive outpatient program down in Louisiana, and we were able to see some great results from that, and obviously outcomes are extremely important, but some of that's shared here. So we do see a reduction in those inpatient hospitalizations, and also a reduction in the ED visits among people that were enrolled. So some of the other outcomes, so that the team that does run this program at the hospital level does use like a geriatric depression scale, a Zung scale. They do a suicide assessment. They do a fall assessment. So they're measuring this for outcomes at the end as a person goes through the program, and then is titrated down out of group therapy, maybe to more individual therapy. You can see we've had some great results, and I know 50% as a number may not look good, but when you look at it in comparison to how the findings and the results are done within some of those assessments, that really is significant improvement, and some of the other quality of life things that we see with that population is been extremely beneficial. So, and program is complementary to any other behavioral health services that the hospital may offer. It's certainly not a competitive one. We see referrals go back and forth amongst both any existing behavioral health services as well as our program. And so again, they can live and breathe together, because there are really two separate type of programs. So these are some of the results just with the depression scale, as well as overall improvement in depression. So again, we want to measure what we're seeing in the outcomes, and be able to get some really good results from that. So in the outpatient kind of rural health clinic, community mental health clinic setting, the opportunity to kind of provide a provider. It's really the simplest method for adding mental health services. So if your community or organization is, off has providers, but again, the wait time's long and they simply want to add another provider in, we can do that. They can be positive from an encounter rate standpoint. So financially, it can work and just help with, again, some of your staffing models that are out there. So it's a really simple model that we've seen work in a number of different states and settings. And again, just to help minimize that. And our providers will, certainly be licensed in the state that they're practicing, and if it's within a hospital, go through your local credentialing there as well, and be set up to do that work. It would be virtual, which we've seen, some great success around, virtual telepsychiatry now, as I'm sure everybody, on here is aware. It's certainly one of the benefits I think that we've seen come from the pandemic. So what that kind of looks like, and from a provider standpoint with organizations that we do work with, you can determine the type of provider you want. So maybe it's a therapist, or maybe it's a psych NP, or even a psychiatrist. Certainly the psych NP and our therapists are probably our two most common that we see. But we find these individuals, we will present them to you and your organization for a chance to meet them and kind of do an interview, but just set up the expectations for them to make sure it's a good fit. So we do have a credentialing team that will assist in making sure that we get the proper credentials and set up with payers done, and then set up a schedule that works within your setting at the hospital, clinic, whatever it might be. So if it's 2 days a week on a Monday and a Friday, or a Tuesday and a Thursday, or whatever it might be, we can try and be accommodating with whatever provider capacity that individual may have. So our team does the quality reviews on each provider, and works with you on that. Our provider would document in the EHR that the organization uses, and you guys are then billing the professional fees and are simply contracted with us as an organization for an hourly rate. So a lot of times we'll see the family practice doctors love to have somebody that can help with medication management with the psychotropic drugs. So the nurse practitioner piece can work, and typically the nurse practitioner is going to see maybe 2 to 3 patients in an hour. Your therapist is going to see probably maybe a patient every hour, every 45 minutes. So again, kind of using your encounter rate and your math, it can be more beneficial sometimes to have a psych NP on board, where they may see up to 12 patients in a day when the practice is up and going, where a therapist might see 6 to 7 patients in a day. But just depends on what you feel is a good fit. So I can pause there for a second if anybody has any questions at this point at all. Without they want to add them in the chat, they certainly can. But okay. So within the emergency department, it's a little bit unique, but obviously those patients present. They're typically in crisis. They're probably at their worst point in the day, or whatever might be happening with them. So that process is pretty simplified, but obviously the doctor on site there is going to go through their normal triage process of evaluating that person. And once they determine that an assessment is done, they can connect into our team of providers, who is either going to be a psychiatrist or a psych NP. And I would say that's somewhat unique, because it does allow them to collaborate and work with the ED team, again, on medication management, maybe help adjust the meds or get them started on something that could be beneficial, and be able to do the assessment. So our team is available 24 hours a day, 7 days a week. They see all ages of individuals, don't have a limit with regard to kids, and with the increased need for kids, that certainly or the attention on kids, that can be beneficial. So typically we're going to respond within about 120 minutes. I know our average is under an hour right now, but that provider would do a full psychiatric assessment, determining the level of care, do a little bit of a safety screening with them as well, and provide any of those medication recommendations, as I mentioned. share that with the ED team and the provider. If everybody's in agreement with our provider, and let's say, for example, inpatient is the level of care that's needed, our team of what we call crisis coordinators that are available to kind of help, again, work and manage the case will then call on the hospital's behalf to find placement. And for those of you that are out there in the hospital setting and know what kind of task and challenge and time that can take to have nursing staff spend hours finding a referral bed, it's a nice thing to take off their plate. And so we manage and own that case until the referral bed is found, and then do the normal kind of transportation, whatever that might look like. If it's outpatient or something other than that, substance use treatment that's needed, we'll kind of refer to what's currently happening within that referral process to get them into the right level of care. So, if somebody stays longer than what is maybe typically, necessary, our providers continue to stay in touch. So if something goes longer than, let's just say, 24 hours, we may reevaluate them and reassess them and see if medication has made a difference. And if they're in, a better place, maybe that assessment then change and everybody's safe to discharge them back to the home or something along those lines. So that coordination can involve, the mental health and the psychiatric, consults that we're doing. We handle all the transfer of documentation when we're sharing that with a referral location. And then we, again, mentioned we call until that bed is secured. So that can be can take a long time. I know on average I think we're at like 45 phone calls per case just to find placement. That may involve the same, facility a couple different times during the day, but we want to try and, where possible, keep those individuals close to home so that transportation doesn't become an issue. But I'm sure, as most of you guys are aware or have been involved, it's not always easy to marry those two things together. So, we do our best to keep them close, but also share, what we have found as far as a bed that or a location that we'll take them and see if they're acceptable to that. So, yeah, and then provide those continual updates to the ED staff. So.
We do have a couple questions in the chat if now's a good time.
Sure. Yeah, absolutely. Let's take them now.
So the programs that you shared for IOP and senior support program, have those been done in rural settings in Missouri?
Yeah, we have 10 hospitals today that are partners in rural Missouri with those. So I'm thinking, I guess just off my head, like Bethany and Brookfield, down to Excelsior Springs, Carroll County. So just a few off the top of my head that I can think of without naming all of them. So yes, it's been a very successful program in those areas.
And if this program has been launched statewide, specifically interested in Southeast Missouri?
That is an area that we are continuing to kind of look to expand to. We don't have any programs down in that part of the state, but there certainly is not any limitations to why. It's just a matter of certainly being able to get those conversations started to have that dialogue. But there is no limitation as long as it's I guess a critical access because of the cost reporting and some of the benefits that go with that from a net impact standpoint. It is specifically geared towards your critical access hospital markets.
Thank you.
Yep, that helps. On the psychiatric side within the ED, obviously I mentioned they'll do the full psychiatric assessment, provide that collaboration, which I think is very key amongst not only maybe on-site providers, but also the ER physicians. So when we're talking about referrals to some sort of existing behavioral health that an organization may have, we want to be sure that we're collaborative in that sense. So constantly review and reassess those cases, those providers do, and make sure that we're, again, getting the best level of care for the patient and having that patient front and center in what they need. So. That kind of summarizes the ED department and with the placement piece. I know that can be a big help and value add with with a lot of the nursing departments and the ED departments that we work with as far as taking that kind of that burden off their plate. So, in summary, really, we know there's a ton of challenges out there that exist for adults and young kids, older adults, whatever it might be, and access is still certainly limited in rural areas. Um, I'm sure most of you have seen or have used, but we do see telepsychiatry as a great proven solution to help address the need for rural access and access into rural areas. I think it's been accepting by all ages of individuals. We certainly have the option to do teletherapy within our senior life program for those individuals that may not be able to make it physically to the hospital for that care in that program. So we've seen it, seen that be successful because I think at the end of the day, people just want to be able to get help, and whatever that might look like is beneficial. So, and then last, there is, we do have provider access. I know today we've got a therapist that's Missouri licensed, and I think she's got probably 24 hours of capacity for whatever it might be. So for individuals that are looking for a therapist, I know we've got a provider today that's got extra capacity. So we certainly are set up to be able to help and continue to recruit and have providers be available as needed. So, and then lastly, there might be a little bit of again a thought that mental health can't be financially viable, but we certainly have seen ways that it does work financially for a hospital, and with our senior life program as well as the outpatient services. Sometimes the ED piece can be a little bit of a loss leader, but we've got a really simple model that we can work within the ED to again kind of just a per month type of fee that allows you to have access to our providers any time of the day and any day of the week to help with that. So we've shown that it can be certainly financial viable and work in a number of different settings in the rural areas. So happy to take any questions. Otherwise, kind of want to keep it simple and short today, and appreciate everybody's time and attention, and happy to address any questions or certainly reach out afterwards. We love just having the conversations. There's certainly no obligations. If you got a question about something, feel free to reach out. I'm happy to help or be a resource or guide you in whatever questions or things like that that you may have. So.
I do have a
Hey
couple
Jay, hey, this is
questions.
Chris Jones. I'm so sorry. I'm with
Nope.
Seymour Health Network. I kind of wanted to jump back to the Southeast Missouri needs. I was answering an email when you were talking about that. Can you kind of elaborate on that again for us? Because we would certainly entertain trying to get these services in our area.
Yeah, so it's I just live in Des Moines, Chris. So it'd be a matter of being able to maybe meet with you to start with if that's something. But we don't have any limitations or things like that as it relates to providing those services in an outpatient setting or a hospital setting in that part of the state. So yeah, whatever you feel like the best place to maybe start, I'm happy to take that offline or follow up. But
Okay.
it does seem like for whatever reason, most of the hospitals that with like our senior life program seem to be on the western edge or western half of the state. But I don't have a rhyme or reason for that, to be honest, Chris.
Yeah. Yeah, no worries. I appreciate it. Just to be
Yeah.
clear, so we're not a hospital. We are an FQHC. Does
Yep.
that matter?
Nope. Kind of
Okay,
outpatient. Yeah, it's outpatient. So, yep,
Okay, thank you.
you betcha. Another question in the chat, Rachel, or?
So, are the services generally contracted through hospitals and outpatient mental health clinics, or can they be arranged through primary care?
The answer would be all of the above. So we do have some some hospitals that are not a rural health clinic designation, but are simply hospital-based care, and so it's treated in, I guess, not to simplify it, but it's treated in the same fashion as a neurology or dermatology or something like that as a specialty service that you can add. So yes, it certainly can be done in a primary care setting, and we don't work just within the hospital markets. We do have some outpatient clinics, community mental health centers, that type of thing that we partner with as well. So
And then, do you
No.
employ APRNs who specialize in mental health?
What was it eight? Was it
AP,
HRN?
nurse practitioners?
Nurse practitioners, yes. So we do have, psychiatric nurse practitioners. Therapists could be professionally licensed LMHC or LISWs, whatever it might be. But yes, we are utilizing, that level of licensure. Depends a little bit on, what the request might be, but specifically within the ED service, that is going to be a psychiatrist or a psych NP that's going to do that assessment and evaluation. And we've seen that be very well accepted for a number of reasons, like licensure, ability to do a little bit more on the medication management side of things. So yeah. But as it relates
And
to outpatient, then we certainly could just have somebody that's a therapist if that was a need.
so piggybacking on that, you provide collaborators within your organization?
We do. We can have each one of our service lines has a chief medical officer that can function as that collaborative physician. So whether it's on the ED side or whether it's within the outpatient setting, our chief medical officer will typically, be in that position to help. Our chief
All right,
medical
I'm kind of
officer on the ED side is actually a child psychiatrist, which is great because she can help our team or just help step in with a lot of the child cases that we see. So, yep.
I feel like you're on the hot seat. Does anyone else on the call want to ask a question before I ask the next one? All right, hearing none. Do you utilize peer supports and bachelor's level clinicians to support providers?
I don't believe we have, and that's not to say that we couldn't, but I don't believe we have. I know a lot of our providers have got a great deal of experience, whether it's with forensics, substance use, whatever it might be. So I know a lot of them have been worked in various different areas and whatnot. So, but I'm not sure if they do or not. That would be probably more directed towards our kind of service line director for each of those. So I can follow up with you, Rachel, and try and get that answer.
Yeah. As a follow up, the question asker was referring more to addressing the social determinants of health.
Um, yeah, no, we wouldn't, I guess, necessarily have that capability. Um, it's probably just a little simpler, model of being able to provide that site provider where needed. So
Hmm. Hmm. Cool.
understanding that, certainly those social determinants are a big part of some of the mental health that we see out there.
Any other questions?